Welcome. We are discussing IVF add-ons. How should we score the HFEA's new ratings system? The hashtag for the event is PET Add-Ons, and the discussion has been made possible thanks to the generous support of the British Fertility Society. I'm Sarah Norcross, Director of PET, and I will be chairing this evening's discussion. Now, add-ons are an optional treatment or treatments, technologies or procedures offered alongside IVF, often at considerable expense to patients and which may not be supported by reliable evidence. And I thought I'd look back in the BioNews archive to see the first reference I could find to the term add-ons. And it was at our annual conference in 2014 when Dr. Yakub Kalaf, director of Guy's Hospital Assisted Conception Unit, spoke about the aggressive marketing tactics of the fertility service providers and the use of unproven methods. He said, these have led to a cookery book method of IVF, where conventional IVF is paired with add-ons of various kinds. I haven't had time to do a full literature search to find out if there are any academic publications that were referring to add-ons before that, but I thought it was quite interesting that this was back in December 2014. So 10 years on, is the situation any different? Well, the Human Fertilisation and Embryology Authority and others have been trying to tackle the issue. So the HFEA regulates all UK fertility clinics, including those that offer add-ons, but tends to only regulate add-ons themselves indirectly. And this is because the HFEA's powers are really restricted because they only concern what can be done to or with gametes and embryos outside the human body. And many of the add-ons fall outside of that scope. But the HFEA have another role in relation to assisted reproduction, and that is providing information. And so they can provide information in relation to add-ons for patients and the wider public, explaining what they entail, whether there's evidence to support their use. And back in 2019, they introduced a traffic lights rating system, placing add-ons into red, amber, green categories, depending on the quality of the evidence. But recently, just in the last few months, the HFEA has overhauled this system and replaced the 3 categories with 5. And these new categories involve criteria including the quality of the evidence, the impact on treatment outcome, and concerns about safety. And they invite anyone who thinks that the list of add-ons is incomplete to propose an add-on for assessment and inclusion. Now, as always, when the regulator publishes something like this in this space, there's a great deal of chatter, with people often, I've noticed, praising it publicly, but privately saying something a bit different. So it'd be good to hear this evening some honest and candid views from both the panel and from the audience in your questions, which you're posting in the Q&A section. So that's quite enough, I think, from me. Let's hear what the panel think about this new approach that the HFEA have taken. So we have 5 speakers for you tonight. We have Dr. Tim Child, Professor Joyce Harper, Dr. Ippokratis Sarris, Tracey Sainsbury, and Dr. Tasha Alden. So our first speaker this evening is Dr. Tim Child. Tim is a member of the Human Fertilisation and Embryology Authority, and he is chair of the HFEA's Scientific and Clinical Advances Advisory Committee, which is often just called SCAC. He's an associate professor of reproductive medicine at the University of Oxford's Nuffield Department of Women's and Reproductive Health. Tim.
Thank you, Sarah, for that excellent introduction and I think overview of add-ons and particularly the background in the last few years. And first of all, thank you very much to Progress Educational Trust. Happy birthday. But thank you for inviting me to open up this evening, I think what will be a fascinating discussion about the thorny issue of add-ons. And as Sarah's mentioned, I'm based in Oxford. I'm an IVF clinician. I'm also an HFEA authority or board member of the HFEA. And I guess from an add-ons perspective, I chair SCAC, which is the largest subcommittee within the HFEA, which has a wide remit, but one of the remits is the add-on system. And I'm pleased that Joyce Harper is speaking after me, because she was an external advisor to the SCAC committee that put the original traffic light system together. So it'd be interesting to hear her views on her work then. So as Sarah has just gone through, so really what are add-ons? And so they are optional, non-essential is an important thing, non-essential treatments that are used in addition to standard IVF or in fact IUI. This isn't just about IVF, it's also potentially IUI or intrauterine insemination. However, the evidence for increased success is often absent or indeed is limited, and there's nearly always an extra cost associated. And it was these three issues which really led to increased concerns a few years ago. And there was various undercover TV programs on this, etc. And that led to the HFEA deciding that something should be done, and then SCAC coming out with the original traffic light system, which I'll come on to. Now, very importantly, as Sarah's mentioned, the HFEA has very limited powers over the introduction of treatment add-ons. It's really outside of the remit of the Act, which the HFEA is there to enforce. And the only time we really have powers are if the add-on is what's called a novel process, something involving directly the eggs or gametes, then potentially there might be a route for the HFEA to have some control. However, we do have powers relating to the information that clinics must provide to patients. So whilst the HFEA does give information to patients, we also require clinics to give information to patients so that they can make an informed choice. So this was the original traffic light system. And you'll see it was very simple: red, amber, green, although I have to say for a colourblind man, which 5% of men are, not ideal, because those three colours look fairly similar to me. And we'll come on to why perhaps the new system has altered that. But very importantly, it was based on these three things. So only high quality randomized controlled trials were used. So these are randomized trials. It's the highest level of medical evidence. So only RCTs were considered. Secondly, the only outcome was whether the add-on increased the chance of having a baby, which obviously is the main reason for doing fertility treatments, but I'll come on to why there might be other outcomes that are important. And the third aspect is that the rating system that was brought in by SCAC was whether an add-on improved the chance of having a live birth for most patients. So that was quite broad. And so, you know, for an add-on to actually increase the success rate of having a baby for most, i.e. the majority of patients having IVF, it's quite a tall ask. And then there were three colours. So green meant that the add-on was proven to increase the chance of having a baby for most patients. Amber essentially didn't know. It could be that there really wasn't much evidence on there, or maybe there was great evidence, but half said yes, half said no. And then red means don't do the add-on because perhaps it's dangerous or it doesn't work. And very importantly, the HFEA traffic light system is aimed at patients, and some other more recent versions, perhaps some other authorities such as ESHRA, which I know Joyce is speaking on, are more focused on the sector, so people working in the sector. This is very, very patient focused. And the HFEA was the first regulatory authority in the world to do this. Now, there was a lot of feedback on this, and I myself gave feedback to the HFEA on my views of it. And there was a view that perhaps the system could be improved. And these are the ways in which perhaps it was thought it could be improved. First, increasing the types of evidence. So what do you do if there are no high quality RCTs? There are other types of evidence, such as cohort studies. It's cohort studies that showed the link between smoking and lung cancer. So it's not that cohort studies can be ignored. If there are no RCTs, it was felt that perhaps cohort studies should be considered, which is the case for Cochrane, NICE, and then Scottish Health Technologies Group as well. Secondly, should there be an increase in the types of outcomes? So not just live birth as the outcome, but how about other important outcomes such as OHSS, miscarriage, time to live birth? The third aspect, rather than consider to add-ons improve the outcome for most patients, how about patient subgroups? How about older patients or younger patients or those with recurrent implantation failure? And finally, should there be increased subtlety or usefulness of the ratings? I mean, it's very nice and simple having just three, red, amber, green. Nothing's ever green, so really it's two, amber or red. But perhaps it could be it could be exploded out a bit more to have a bit more subtlety. Now, the HFEA we spent over 2 years working up this current add-on system. This wasn't something that was decided by a committee in a dark room. There was significant external involvement. First of all, with patients, with one-to-one patient interviews and a large online targeted patient survey. Licensed clinics were involved through the LCP, or the Licensed Centres Panel. Staff working in the sector were asked to respond, and this is staff at all types of staff working in the sector, through a large online survey, asking them things like, should there be 3, 4 or 5 outcomes? Should we be looking at different patient groups rather than most patients? All these sorts of questions. Stakeholders, so the patient organisation stakeholder group, and also signatories of the consensus statement that I'm going to come on to. Then, once we got a bit further through, we involved the public in terms of the draft web pages. There was a user acceptance testing to make sure that the web pages were felt to be suitable for patients. Again, this is aimed at the patient sector. And then the actual working through the data, it was very transparent. It was a published methodology that was used. There was an external medical librarian who put together the search strategy, along with a professor of reproductive medicine who works with big data. They put together the search strategy that was then checked by SCAC. And then we had another external expert in systematic reviews who actually helped collate the evidence. But again, within SCAC, as I'm going to show you, there was also a lot of expertise. And then finally, SCAC itself. So SCAC, there's 14 people on SCAC. As we mentioned, I'm the chair of it. Very importantly now, and this wasn't the case beforehand, but now it's a fixed term appointment. People used to be on it for years and years before. So now it's a fixed term appointment, the same as it is for being on the HFEA board. Once your term finishes, you're out and we appoint new people. So we're just about to be interviewing 3 replacement positions. Very importantly, of the 14 people, 8 work within the sector. So there are 6 clinicians and 2 embryologists. And of the clinicians, it's a mix of reproductive medicine specialists, clinical geneticists, and urologists/andrologists. And then we have people from other areas such as patient support, cellular biology, and reproductive genetics as well. So after this 2 years of work, going out to the sector, coming back, going out, coming back, many iterations, it was felt that this was the best approach. Now, clearly, it is not as simple as the last one. The last one was great. I found it very helpful in practice when I spoke to patients, but it was probably a bit too simple, really, with just only live birth, only RCTs, and only those 3 different categories, essentially 2, because things were very rarely green. So just to show you on here, the top one, green, and you'll notice the symbols in the middle there are essentially for colorblind people. So I think I personally, from my point of view, I found that helpful. So green, on balance, findings from high quality evidence shows that this add-on is effective in improving the outcome. But an add-on can only be green if there's at least 1 RCT of a good enough quality. So to be green, that can't be on cohort studies. You have to have an RCT, a decent quality RCT from that. Amber means that it's conflicting. There are some studies showing it works, some studies showing it doesn't. So it has been studied, but we're not sure. Grey, which would have been mixed into amber before, grey means that we don't know. The studies just haven't been done. Black means the studies have been done and it's been shown not to work. Red means the studies have been done and it's been shown to make things worse, or potentially there are safety concerns. Now, an example of a green one would be elective freeze-all to reduce the risk of OHSS. So in all patients, it's been shown that reduces the risk of OHSS. That outcome wasn't shown in the old, wasn't used in the old criteria. An example of amber, endometrial scratch. If you use that for most patients, it does not improve. We don't know if it improves the live birth rate. I should say we don't know because studies are conflicting. But if you look at endometrial scratch just in patients with recurrent implantation failure, then it's grey because the studies just haven't been done. Black, the use of PICSI, which is an add-on to ICSI. So if you do PICSI compared to ICSI, there is no improvement in the live birth rate. So we know it does not help. Then finally, red, endometrial receptivity testing has been shown to lower the live birth rate if you use such a technique. This was a decision tree that we came up with. Again, it went out and was checked with the sector, and it fitted in with the methodologies used by Cochrane and others. And this is all online. I won't go through it now. You can find this on the HFEA site, but essentially you follow that through. If there are RCTs, great. If there aren't, it takes you through to look at perhaps other types of evidence there. Does it meet the criteria? And then the committee consider whether from that we can put whatever the add-on is into whichever outcome rating. And I'm just going to show you here PGTA. So this is a good example. So if someone's interested in PGTA, they can look at this. So PGTA is rated red for the chance of for the chance of improving the live birth rate for most fertility patients. And the reason it's red is because there's evidence suggesting that if most people have PGTA, you might actually lower your chance of having a live birth. Therefore, it's red. However, the study suggests that the chance of having a miscarriage is lower with PGTA, and so that's why that's green. But once you start looking at miscarriage or live birth rate in older patients, and logically you might think, well, probably PGTA is going to work better in older patients. There just aren't the studies to show that, either RCTs or good quality cohort studies, and therefore we rated it grey, as in we just don't know at the moment. So all of this was published on the 19th of October 2023, and that coincided with an updated consensus statement from the HFEA plus 8 professional and patient bodies, a statement on add-ons and the importance of monitoring the evidence base for add-ons, and how this needs to be add-ons need to be promoted or offered to patients in a responsible manner. Now, after we published this, we had an excellent feedback from the media and also from patients. Now, having said that, things can always be improved. And quite rightly, when Sarah said at the beginning, this is my last slide, as Sarah said at the beginning, that whilst people may say in public things are great, maybe they won't in private, or vice versa. So we are always listening to see how we can improve things. My view is the current system is a significant step up from what was the previous excellent system. Can it be improved? Undoubtedly. But it's the continued work. So from an HFEA perspective, we are continuing to promote our add-ons information, both online, but also talking to clinics. There's a proposal that's gone from the HFEA to the government in terms of when the Act is being renewed, the Act of Parliament, and ideally we would like more power regarding add-ons. At the moment, as we said, we have no power really, or minimal power to regulate them. And just the final thing is to say is that we, the HFEA, were the first, as I said, regulator to really look at add-ons and to publish on this. Since then, there has been much more work in this area, in particular from the Cochrane Group and also ESHRE's good practice recommendation paper. But they're quite different because particularly ESHRE is very much, as I mentioned, aimed at the sector. In my view, it's not as clear in terms of the outcomes. It's word outcomes rather than perhaps outcomes fitting into particular slots and people making a decision it's there or it's there. But it is very, very useful. I have reviewed the similarities between the HFEA outcomes and the ESHRE outcomes, and in general, they are pretty close. And I think there's always room for improvement, and I look forward to hearing from the rest of my colleagues now.
Next this evening, we have Joyce Harper. Joyce is Professor of Reproductive Science and leader of the Reproductive Science and Society Group at University College London's EGA Institute for Women's Health. She was a member of the working group that produced the European Society of Human Reproduction and Embryology's good practice recommendations for add-ons. Now, I sort of became aware that we are in a bit of an acronym soup event tonight. So that European Society, ESHRE, and so that's another one to add to your list. But Joyce is also the author of the book, Your Fertile Years, What You Need to Know to Make Informed Choices. And she's the editor of a book about pre-implantation genetic diagnosis.
Good. I'll move on straight away. So yes, the history of add-ons, always a great one. And I think we have a very controversial topic here. And I'm someone who's been both sides of the table because I've also been an IVF patient and I've been offered add-ons. So I know what it's like to be a patient and to be someone working in this sector. And my history started with add-ons. I see someone who's already written a question about PGS. So we used to call pre-implantation genetic testing for aneuploidy back in the old days. pre-implantation genetic screening, or PGS. And I'd been working on pre-implantation genetic diagnosis. I know Marilyn Monk's on the call. She's one of the pioneers of PGD or PGT, as we'd like to call it now. And when I was working in the field back in 1992, keep losing a few decades, 1992, the story of this, using this technique, which was developed to help couples that were carrying a genetic disease to have a child not affected by that disease, was very soon taken up in the sector by a couple of labs in the USA that thought, well, we could use this technology to look at aneuploidy within patients going through IVF. And so my experience with I think of PGS or PGTA as one of the very first add-ons, where it was being claimed back in the early 90s that this technology was going to improve your chance of having a baby. And the first papers came out, and I thought that's not going to work. And then the next papers came out, and the method has slightly changed. And as time went on, every paper was slightly evolving the technique, but they all claimed that they were going to improve the chance of having a baby. And that was when my shekels first rose up with this whole using technology that there was no evidence for, and making very bold claims that it was going to improve your chance of having a baby. And then these are the papers I've been involved with. And the top left one came about after the HFEA meeting, the HFEA annual conference, where time-lapse first arrived. And I can't remember whether it's 2009 or 2010, but we published this paper at the beginning of 2011. And Professor Daniel Bryson from Manchester and I were walking around the exhibit hall, and we saw this new time-lapse machine, which looked great. And the guy selling it was saying it's going to improve the chance of your patients having a baby because it's going to improve embryo selection. And Daniel and I, specifically me, gave this guy a very hard time. And I just thought they had no evidence for this at all. We asked if they'd done an RCT. They'd done nothing. They had hardly even grown any normal human embryos in it. So we got together with Chris Barrett, Christina Maglin, and Kirsty, who I know is also on the call today. And we wrote this paper about when and how should new technology be introduced into the IVF lab. And I don't think we did call it add-ons then, but things moved on. And these are, as I said, the papers I've been involved with. And as Tim said, I was part of the SCAT committee back that had helped create the initial traffic light system. And this paper we published in 2017 was as a result of that. And we went through the add-ons that the HFEA had looked at. And quite interestingly, in this paper, we had said that a green add-on could be what we call commercially embryo glue. And just hold that thought, and we're going to come back to that. And here in the middle, we've got the new HFEA guidelines that have been mentioned already that I'm going to go through now. So this is the team, and Sarah was part of this team as well. We had a very hard task. We wanted to look at all the add-ons that we could think of. So the HFEA list is just 13 add-ons. In the HFEA guidelines we published last year, we looked at 42 add-ons. So it was a very painful and long procedure to do this. And I don't think that HFEA necessarily have the clearest way, and I don't think the HFEA necessarily have the clearest way. I think it's a complicated thing that we're trying to do. We're trying to make this accessible to health professionals and also the public. So I think this is an ongoing project that needs to be continuously reviewed. But within HFEA, after many, many, many discussions, we decided to separate these tests into diagnostic tests, laboratory interventions, and clinical management. So this paper is free to download. Just put even the rough title in and you'll get to a copy of this. So I got a headache making this slide today. This is as Tim said, this is the new ratings from the HFEA, which mainly, I agree, not exclusively, but is mainly looking at live birth rate, but it does take into account other things. And with HFEA, we were looking at efficacy and safety. So our recommendations, the terminology we used, are that something is recommended if the test intervention can be applied to most patients or those patient groups for whom it may be of relevance, and the recommendation can be adopted as policy in most situations. Our recommendation could be considered if it can be applied after a thorough discussion of possible benefits and risks and with close monitoring, follow-up and evaluation. And then we've got two that are not recommended. One that says currently not recommended for routine clinical use. So the test intervention should not be applied routinely to patients at this stage, but this may change when more evidence on efficacy and safety becomes available. Optionally, the intervention can be applied to a specific patient group. So hovering there, but not recommended routinely yet. And they're not recommended at all based on safety concerns and or lack of efficacy and or lack of biological rationale. The test intervention should not be applied to patients. Further evaluation of these test interventions can be done, but only in strict research settings. And what gave me a headache was I tried to superimpose the HFEA recommendations onto the ESHRA ones, and I couldn't. Besides the green, I couldn't really do it. But I'd be happy. I know Tim said he's looked at it, so I'd be happy to look at this and discuss that further. I sort of put these two in the sort of middle of these. So let's go through. I'm just going to whiz through these. This is the diagnostic tests. I'm just going to highlight what's been. Anything in yellow were things that could be considered or were recommended. So screening hysteroscopy, we wrote specific circumstances. So it can be considered in patients with a recurrent IVF failure. Laboratory interventions, we had artificial oocyte activation and artificial sperm activation, both recommended. I won't read both of these out, but only in very specific circumstances. Both were not recommended for routine clinical use. And microfluidics for sperm evaluations and selection said it can be considered. And clinical management, so I said at the beginning to remember the embryo glue or the addition to the transfer media, the hyaluronic acid, which they're the same thing. So in that 2017 paper, we said should be green, but HFEA have never made it green officially. And ESHRA, we looked and talked about this because we knew that this was the one thing that we didn't agree with the HFEA, but we felt it needed to be recommended. And the monitoring of multiple pregnancy rate is still advisable. And then in clinical management, none of these were recommended. And then I tried, sorry, I apologize. This is a terrible, terrible slide. Never normally make such a terrible slide. But I tried to see whether the ESHRA and HFEA guidance agreed. So this is the HFEA's here from their website. I do think it does roughly agree. I think obviously the embryo glue does not agree. In our view, this should be green. Time lapse not recommended to improve live birth rates. A fabulous incubator, but not. There's no evidence for that. So, yeah, I think we could discuss this again in the questions. I won't dwell on this now, but it's complex. That would be my statement. It is complex. So in conclusion, IVF treatments continue to be developed. And unfortunately, from our ESHRA study, none of the 42 add-ons were based on high quality evidence. We didn't feel any of the studies, any of the RCTs, and we did take into consideration other studies as well. We didn't feel any were high quality, and only 4 we rated as moderate quality evidence, which meant that 95% of the recommendations in the ESHRA study guidelines are on low quality evidence, which is not good enough at all. We really need to change that. And I think we really need to change it because so many of these add-ons are offered at such a huge rate across the world. So there are clinics many years ago in the US that were offering pre-implantation genetic screening for aneuploidy for every single one of their patients. And then we've got ESHRA and the HFEA saying it's not recommended. So it's, in my view, a travesty that we have not done high quality randomized controlled trials to really take these important issues into consideration when there are so many, literally hundreds of thousands of patients around the world using these techniques and paying for them. And I really think that we are misleading them. And when I was on SCAC, I don't know if anything's changed, but the HFEA does have limited powers. And if a new treatment came to them, they couldn't put them in a sort of holding cell. I felt that there needed to be a clinical trial license only, where a new technology comes in and the HFEA can say, right, you can only do this part of a clinical trial. But when I was on SCAC, we didn't have that. We had to approve a technique or not approve it. And we had very specific guidance on how we could not approve it. And I think the HFEA needs to increase the list of add-ons. I have tried many times to get certain things added on, but they haven't been. And I appreciate it costs lots of money to do that. But my big question I want to put to everyone today is that will anyone actually listen? So we've had the HFEA have, for example, PGTA has been read for many years. It wasn't read when we first did it. It was amber. And then some studies came in that we felt made it go red, and we changed it to red. And ESHRE doesn't recommend it, but it's still done around the world. And that list carries on, assisted hatching, et cetera, et cetera. If you Google these techniques and imagine you're a patient, you'll see so much misinformation about how successful they are. So my big worry is that we're doing all this great work from the HFEA and ESHRE, but no one will actually listen. And if you want to contact me, lots on social media, just contact me at Prof. Joyce Harper. Thank you.
And following on from Joyce now, we have Dr. Ippokratis Sarris. Ippokratis is Director of King's Fertility and Consultant in Reproductive Medicine. He is an Honorary Clinical Senior Lecturer at King's College London, and he is co-editor of the book Training in Obstetrics and Gynecology, The Essential Curriculum. It doesn't sound like light bedtime reading to me.
So I always like to put up my disclosure of interest. I think the most important ones are the ones which are in bold, because effectively I am a director of a clinic in London and a consultant in reproductive medicine. So obviously everything I'll say is for my clinical sort of hat. Now, it is true to say that there's been a lot of advances in IVF over the years, significant milestones in ovarian stimulation strategies, lab innovations, embryology techniques, and of course, what we do with the patients. And that can be evidenced by the fact that over the number of decades, the success rate for all age groups, apart really from the older ones, have increased over time. But if we sort of extend this graph to where we are now, what we've seen is there's a plateau of pretty much most of the age groups' success rates. So approximately 1 in 4 embryos that we put back overall will result in a baby. So if that's the case, why does it always go wrong so frequently? Well, we have to go back to some very basic stuff. Of course, human reproduction is highly inefficient. There's a maximal chance of conceiving a clinical pregnancy in only 30% of the times, and there are multiple points where problems can lead to a failed pregnancy. But it's true to say that 60%, so the majority of failed conceptions, will be preclinical, so before you will even know you're pregnant. And what ART has done has enabled us to open this black box and to explore it a little bit more, because in natural conceptions, we would never know. So it is true also to say that a lot of the add-ons are used, or at least are suggested, after failed treatment. And when there are multiple failed treatments, that's what we refer as recurrent implantation failure. And of course, this is just a term that describes unexplained IVF failure, and it's used to sort of focus discussions and potential therapeutic options. But it's also true to say that there have been no significant advances in effective management of this. And of course, as we've heard, treatments and tests for recurrent implantation failure and add-ons have become associated with accusations of poor and exploitative practices. However, unexplained repeated failures of IVF treatment is a frequently encountered, distressing, and difficult to manage clinical problem. And you're not meant to read through this slide, but what I want to illustrate here, although there's a difference in sort of the use of add-ons and the use of tests for various treatments or failed treatments, and the difference between practitioners in the private setting versus, for example, a public or university setting. What is interesting is one dwells into the numbers, is that both groups have a significant proportion of answers that would be yes to pretty much most things that we would consider red on these traffic light systems, or not advisable in these various sort of ESHRE guidance and whatnot. So although we know things don't work. Still, around the world, most clinicians, doesn't matter what setting they're in, will recommend something to the patients. Because in many ways, one could argue that insanity is doing the same thing over and over again and expecting a different result. So of course we have to change something. Or is that actually correct in our field? So a couple of examples that I just usually bring up with my lectures. This is a very neat study that showed they can do exactly the same stimulation to the same women without changing anything. And every time, a quarter of the patients will have a completely different result to what they had before. So they either over-respond or under-respond. And that is not a predictable event. So we can't tell when it's going to happen. And of course, we know that if you put over and over again euploid embryos, this landmark paper from a few years ago showed they can have after 3 transfers a cumulative live birth rate of almost 93%. And although it was not powered for the 4th transfer, actually that number goes on. So maybe repeating the same thing is not a bad thing, and actually that's all we need to do. Now, of course, we just spoke about how PGTA is an add-on and how it is rated red. So if we decide to do the same without using PGTA, for example, and to see if we can have the same chance of success, that's sort of almost 95% implantation rate, then depending on the age, when you're in the younger age group, so less than 35, the numbers of the transfers you have to do is pretty similar. But as we go through the age group, because aneuploidy goes up, which is natural phenomenon, we can see that you might end up with 7, 13, or even 27 embryos that have to be transferred before we can actually have the same success rate. And unfortunately, most would consider this way before you reach those numbers to start talking about all the other add-ons we're talking about, immunology, scratching, and whatnot. There's also some limitations in defining recurrent implantation failure and failed treatments. They imply you have a good quality embryo. It assumes a normal uterus. And of course, it doesn't necessarily take into consideration what else we do with our patients. And we should not forget that there are patients with predictable low chance of ART success. And the gynecologists among the group will recognize a lot of these conditions as well. So you can't bring everybody in just based on embryos and on lab parameters. There are other issues that have to be taken into consideration as well. And I'll be a little bit controversial just because I should, but present company excluded, but it is true that a lot of clinicians and a lot of these social media opinions that are out there are not able to critically read and understand data. Just cherry picking a single study to prove one's point is meaningless and actually can be misleading. And there's always evidence from a publication to agree with any point that we want to believe in. Of course, the real question, this is where guidance comes into and what the HFEA and ESHRE is trying to do, is there robust evidence from a number of well-designed, properly powered, well-conducted studies from trustworthy sources that have been analyzed and constructed a proper picture. And in this sort of made-up example, you can see that you have different studies, and if you just pluck the first one, you'll believe one end of the story. If you pluck the last one or the third one, it'll tell you the opposite, and when you put it all together, you have a different result. But there are, of course, challenges in all guidelines and traffic light system. And that's the fact that there's very little evidence out there. There's a lack of consistency in definitions. There's very little evidence that pits different interventions against each other. And that includes, unfortunately, already established practices that we have. So a lot of the recommendations which are out there have to be derived from expert interpretation of the available data and your opinion rather than fact. So when we say that something's not recommended, this of course implies that the investigation or intervention is not to be routinely offered, but does not mean that it should not be recommended necessarily to be used in any circumstance, since the evidence base really is not there to be really that didactic about that approach. And of course, not everybody we see in our clinics will fit into these sort of and the trials that have been done. So there's a neat little paper that showed that this particular sort of assessment of 9 major clinical trials in the context of using fertility drugs, only a third of the patients fit within the criteria of these randomized controlled trials. So as a consequence, a lot of the patients have not been subjected to trials that we can use. And of course, that's when we come to the pitfalls of extrapolation. So effectively, you might have patients that don't fit anything, or any trial that has been done there. So you assume that you have the data. This actually is a real sort of graph of what happens with bacterial growth over time. So if you just take that snapshot, you can see there's exponential growth, this logarithmic scale. So as time goes forward, you should expect a theoretical infinite growth. However, the reality is very different. When you look at the entire picture, you get a very, very different approach. And actually, if you wait long enough, all your bacteria are dead. So you can't always extrapolate from the data that you have to fit patients that have not been studied. Now, if we look at our famous Gartner Add-Ons hype cycle, when everything started, and maybe we're talking about the 2014 sort of era that we just heard about, there was this peak of inflated expectations. And of course, the HFEA came in and crashed everything down with this traffic light system, this trough of disillusionment. But we have moved on. And I do feel that this new traffic light system has brought us to the slope of enlightenment, because there are different measures, different metrics, and more nuanced sort of approach to it. Now, I don't think we're yet at the plateau of productivity, but we're definitely heading in the right direction. So if one would ask how I would rate the HFEA's new traffic light system, well, let's go back to its own rating, and I'll put my hand up and say that I rated it red for the previous traffic light system. But this one, I'm going to give it, I think, a very respectable grade. I think it's a great advancement. It, of course, still needs to be seen how it would be utilized. It is very complex in its metrics and what is included and not, and if everything's included. So I think it still has a long way to go, but I think it's a much better system than the one before. Now, we should not forget what it's all about. It's about our patients. And most importantly, we should appreciate all the mental health effects that fertility patients undergo. There's a significantly higher mental health issues in patients with unsuccessful treatment or with repeated implantation failure and repeated cycles as well. And there's some evidence potentially to point out that the levels of stress will fluctuate in response to the amount of supportive care that we give our patients and the investigations that we undertake. And of course, that's why any guidance really concentrates on the fact that since we don't have evidence about what we should or can do, we should look at the patient and counsel them and listen to them and be very supportive and use clear and honest language. But really beyond that, there's not much else that we can offer. But what is important is to look what's the prognosis of patients with repeated IVF failures. So from the HFEA data itself, that we can see that even after 10 cycles, although the per cycle success goes down, and of course the age goes up as well, actually you still have some decent chance of success with every cycle that you undertake. So therefore, if you look at the cumulative chance of success, what has been shown is that you can have quite decent success considering the cases that we're talking about over time, as long as you remain in treatment. And this is very important because the very large dropout rates after each unsuccessful treatment, even if money is not the issue. And we can see that after the first cycle, a quarter of patients will stop the treatments, and after 5 cycles, 50% of patients will not be in treatment after that cycle. So patients do need to remain engaged. They have to feel listened. And this is my question. If a patient wants an add-on and does not want to wait for the definitive RCT, should patient autonomy be considered and respected, of course with appropriate counseling, or should we take an absolute approach? Because really, if patients drop out of the treatment program, there's no success. So I'm going to pose a question, quite controversial one. Is prudent and sparing use of add-ons helpful in order to keep the patients listened to and remain in the program, which is what will ultimately lead to success? Well, if I had to rate my own question, I'll probably rate myself with the grey, because we really don't know if this is true or not, and there's no real evidence to be able to test it. And with that, I would like to thank you very much.
Our next speaker this evening, it's quite fitting that Ippokratis touched on this towards the end of his presentation, is Tracey Sainsbury, who is a fertility counsellor. Tracey is co-author of the book Making Friends with Your Fertility. She was previously an executive member at the British Infertility Counselling Association, and she has worked for the leading patient support charity in its various guises for quite a long time, Issue, Child and Infertility Network UK, and then Fertility Network UK. She's very much embedded in the patient sector, as well as being a counsellor.
This evening, I'm going to focus on the patient's perspective and just how psychologically challenging the assisted conception journey can be. And I'm going to share with you my experience from both my personal and professional perspectives, and reinforcing just how important the rating system is, even if patients do choose to ignore it, which sadly can happen quite often. But again, I think it's really important that the HFEA don't take it personally. Let me see if this moves. There you go. The HFEA serves as a crucial guidepost for patients navigating the complex landscape of fertility treatments, influencing not only their decisions, but also their experiences and outcomes. First, let's think about the context. Infertility is a deeply personal and often emotionally taxing journey for individuals and couples. The desire to conceive a child can be overwhelming, driving many to explore various treatment options, even those beyond conventional medical recommendations. I'm really going to lower the tone, but I've had journalists ask this week, for any Kardashian fans, about preconception vaginal steams and drinking semen. I do wish the HFEA could regulate Counsellor questions as well. That would be great. But this is where the HFEA rating system steps in, really, is when people do look to have treatment in a licensed centre. And apologies for note turning, I'm old school and I can waffle on. Patients understand that the HFEA, as the UK's independent regulator for fertility treatment and research, plays such a pivotal role in ensuring transparency, accountability within the field, and the rating system for treatment add-ons aims at evaluating the effectiveness and safety of additional procedures or services offered alongside the standard fertility treatments. And patients can easily access the HFEA's rating system, which categorises into the 5 ratings based on the clinical effectiveness and safety. And I think that's really easy for patients to understand, that a green rated add-on is supported by strong evidence demonstrating the benefits and safety. And it's really frustrating for lots of patients that there are no front page green add-ons. It's almost like, what is the point of the green if nothing's green? Rated greens means they're generally safe for patients seeking fertility treatment, and the HFEA gives its stamp of approval and support patients with their choice of add-on. So there can almost be a feeling or a fear that patients are doing something wrong if they are going to go ahead and embrace treatment with an add-on, even if their consultant recommends it. Red rated add-ons highlight awareness of the potential safety concerns or a potential to reduce the chance of a positive outcome. But a question I'm often asked is, if the HFEA don't approve and don't approve strongly, why is it even available? And especially, why shouldn't I go ahead with it if my clinic will do it and I'm paying? So that level of confusion can be really impactful emotionally as well. There's a desire to want to tick every box. For many patients, amber, grey or black, where the effectiveness can't be rated due to insufficient evidence, or where outcomes confirm the treatment outcome is not affected, these seem to be routinely seen as, go ahead if you want to, but pause and read a bit more first. And again, if they are available and possibly not enough is known, but I want to pay for it and the clinic offers it, why should I feel bad about going ahead? There's another frustration, is, why can't you use me for data? I want to be part of the solution. I want to prove that this works. I've got a good feeling about it. And quite often I'll hear that people phone the HFEA, speak to somebody, and it's the very strong message not to go ahead is heard, but patients still want to go ahead and wish they hadn't called. So in these cases, that need for compassion is really, really important. Researchers for many years highlighted the psychological impacts of unsuccessful fertility treatment. And patients, especially those who can afford to go private, but who want to spend their money wisely, want to have done as much testing as possible ahead of treatment or during the treatment prior to egg collection, in order to optimise the chance of a successful outcome. Thinking more about the patients, let's delve into how this rating system impacts. Firstly, it empowers them with knowledge. by providing clear and accessible information about treatment add-ons, and patients can make informed decisions aligned with their values, preferences, and medical needs. And this transparency and easy access promotes a sense of autonomy and agency, both of which are so important aspects of patient-centred care when so much vulnerability is there because patients don't have the ability to control or influence the outcome of their treatment. Secondly, there may be an assumption that the rating system helps to manage expectations. Infertility treatment is fraught with uncertainties, and patients often cling to any possibility of success. However, by distinguishing between evidence-based add-ons and those lacking scientific support, the HFEA rating system promotes realistic expectations, and as adults, you might think this will minimise the risk of disappointment and emotional distress. But sadly, that is often not the case. For me, personally, the unconscious highs that treatment can generate are primal. You're in with a chance to create new life. It's like Earth, Mother Earth, you're put here to have a baby. That's as high as you can go. And the lows, no new life, are as low as you can go, failing as a woman by not delivering the baby, failing as a human by not procreating. And Fertility Network UK's research, published both in 2016 and repeated, published again in 2022, both found around 40% of people had suicidal thoughts at some point during their fertility journey. For me, my thought when IVF wasn't working was very much, what's the point if not to be a mother? Not ready to end it, but very challenging of the essence of me. Back to the rating system. Thirdly, it promotes safety. Fertility treatment can be physically and emotionally taxing, and patients deserve assurances that the interventions they undergo are both effective and safe. By highlighting potential risks associated with certain add-ons, the HFEA rating system safeguards patients from harm, fostering trust and building confidence in the healthcare system. But I previously mentioned my own fertility journey, and for me, I'd have not listened. Again, on a primal level, I'd have wanted to push boundaries. And I did. I'm not normally a trendsetter, but I clearly remember attending an issue support group meeting back in 1998, 99, probably 99, early 2000s, which was held in someone's house. And the person hosting had a box of test tubes on a table, ready to have bloods drawn and shipped to the Share Institute. My God, it was so new and so American. And my husband and I looked at each other in disbelief. Was someone really, really going to go to such lengths to have a baby? My God, we were so naive. We never expected that to be us. I'd had pregnancy loss with previous partners and was embracing donor conception with my husband. And back then, you never got the same sperm donor twice. So no testing was possible, as I never reached the magic 3 pregnancy losses with the same egg and sperm combo. But I wanted to know everything, no stone unturned. And this wasn't me just as a result of infertility. This is just me. So after 33 grand, which was a heck of a lot then, I was volunteering with Issue and had a friend who worked in the labs at St George's, and they did immune testing for a huge range of medical conditions. And I asked if I paid for it, if they could check my CD56 markers and a few other things that I'd read on an American website. Even websites were quite new back then. And they said they could, but they got no way of interpreting the results. My fertility consultant shook his head. He put his head in his hands. He was mortified that I was doing all these things, but I was a woman on a mission. So we got the results done, went off to see a prof at the Portland, and IVIG was suggested, but we wanted to have 2 or more children, and the costs of that would have made a second cycle prohibitive. If we'd gone ahead with the first cycle and it had worked, there was no way that we'd have been able to have a second. So for us, this test that wasn't in any way supported, it wasn't even a proper clinic test, I'd kind of ad hoc it together, gave us permission to stop treatment, believing we'd done enough. But if I could go back in time, if the information was available then, I'm not sure I'd test again, especially given the increased amount of research, which, to quote the HFEA website, It's now becoming clear that NK cells are beneficial for pregnancy and work in cooperation with the placenta so it can successfully become established in the uterus. But I hadn't at the time, my clicking clock hadn't got time to wait for all that research to become available. Many of my clients who've experienced recurrent loss have a high AMH and a good number of embryos created when IVF becomes the plan. The HFEA rating system, when you look further in, does share that PGTA is rated green for most people to reduce miscarriage, even though the front page rating does not. I can recount many cases of clients who've experienced unsuccessful treatment, pregnancy losses, including later losses, sadly, and eventually they've included PGTA to find no euploid embryos suitable for transfer. For them, a really common complaint is they wish they'd have spent more sooner and avoided the heartache of loss. When people with no experience of miscarriage read about pregnancy loss, it can feel, oh, you've lost a baby, and it's like that. Whereas, as you know, sadly, it can drag on for many months that can be so impactful when that biological clock continues to tick. There seems to be a common theme with rising costs outside of treatment, as well as with private clinics, to bring on any test to optimize success and reduce the duration to pregnancy. Costs are so very important, with your unconscious thoughts screaming you can't put a price on a baby, but there often is a mortgage to pay in the mix ahead of treatment. But for clients who've experienced miscarriage and those who know someone who has, knowing this test can reduce the risk of miscarriage, the HFEA say for most people, could be clearer and possibly on the front page. It's 5 years ago now since we had the first consensus statement promoting transparency from clinics and fertility professionals to patients in licensed clinics around add-ons. It was essential at the time, and it continues to be essential for regulators to approach patients with compassion and empathy, recognizing the profound emotional stakes involved. While some patients may choose to self-fund add-ons not recommended by the HFEA, it's crucial to engage in open and non-judgmental dialogue, respecting their autonomy whilst offering support and guidance. Ensuring clinics provide transparency around add-ons not supported by the HFEA, regulating that information and for everyone to stay in touch with research that may promote a change in the rating can give patients enough information to make informed decisions. And the HFEA rating system for treatment add-ons serves as a beacon of clarity and empowerment for patients navigating the complexities of infertility treatment. By providing evidence-based guidance and prioritising patient safety, this regulatory framework ensures that individuals and couples embarking on the journey to parenthood do so with knowledge, confidence, and hopefully compassion.
So I'm going to go straight now to the final speaker, Dr. Tasha Alden. Tasha has had multiple rounds of unsuccessful donor egg IVF, both in the NHS and in the private sector, and she has had experience of various add-ons. In her day job, Tasha is a senior lecturer in contemporary literature at Aberystwyth University, and she is currently researching the use of language in relation to fertility treatment. We're really looking forward to hearing her personal opinions on this now.
I should start by apologising, as I would to my students, for reading from a script rather than from slides, which I know is more engaging, but I also know I can get carried away talking about all this. I wanted to make sure that I stayed to time. So as Sarah said, I'm Tasha Alden. I'm a lecturer in English Lit at Aberystwyth University in Wales, where I work on contemporary writing. And I'm just beginning a project on language and narrative formation in fertility treatment. This work's come out of my own experience of trying to have a family with my partner. And I'm going to start by sketching that experience out a little bit to explain how we came to use add-ons and what that was like. My partner and I both have fertility problems. Bingo, well done us. We started donor egg and sperm treatment over a decade ago, and as Sarah says, we haven't had any luck as yet, although we've not given up either. We began our treatment at our local NHS clinic, where we had 2 rounds of own egg treatment. The clinic suggested, at that point I was surprised, to my surprise, diagnosed with POI, primary ovarian insufficiency, which was a surprise, as I hadn't actually had any symptoms at that point. The clinic basically said at this point you should move to double donor treatment, and my sister offered to be our egg donor. We had a pretty textbook cycle. It went really well, which was really nice after the disaster of the last two. And we basically hit the jackpot with 6 blastocysts. We thought we were pretty much home and dry. We didn't really know very much at that point. It was a bit of a shock after having had a long road to that point and having such a perfect looking cycle with my amazing sister, that it didn't work. And I can only call what I did next panicking. I panicked. I decided that we needed to throw the kitchen sink at our next cycles, and we bolted from the NHS to the private sector. I had some friends who'd been treated at a private clinic, which had great success rates, and they seemed incredibly thorough. They made a really good impression on us. It was very easy looking back with the luxury of hindsight to frame that the extra things that clinic were offering that the NHS weren't offering as things that would maximize our chances, that that the NHS wasn't as innovative as the private sector, and that was kind of where we were, what we were hoping for. I hadn't expected to use a huge number of add-ons. To be honest, I basically put myself very much in the hands of the clinic. That was really what I was paying for. I thought I wanted to be able to hand that worry over to them. And when they recommended, we did some tests, they recommended add-ons, and I was ambivalent, but I also didn't feel in a position to go against their advice. So I started on a bit of a roller coaster of treatment. We started off with steroids and intralipid infusions, moved on to Humira and IVIG, had a hysteroscopy, and empirical treatment with Clexane. Some of these weren't a big deal. Some of these treatments were time consuming. They delayed our treatment quite significantly as we waited for results of the Humira, for example. Some of them were invasive. The side effects of one of them made me pretty ill. And they cost, obviously, a pretty alarming amount. We could only afford this because my partner inherited some money when their father died. So I haven't rejected add-ons out of hand. I'm still interested in them. When we looked into the recent cycle, we looked into the ERA test, for example. We decided against it when I saw the large scale study on it that had come back as being pretty inconclusive. I feel a lot more confident now in making better informed decisions, but that element of doubt, that fear that perhaps you've just ignored the thing that might make your family happen, doesn't really seem to go away. So when we started out, there wasn't a traffic light system, and there really wasn't anything out there to guide us. There was some information online in sort of academic articles that I frankly didn't really understand. And there were discussions on online message boards, fertility message boards, about people who've had success with add-ons after multiple unsuccessful cycles. I remember reading these pretty obsessively, trying to make, in retrospect, a clinical decision that I was simply not equipped to make. As patients, especially where our treatment has failed, the desire for innovation, to change things, to take back control, to coin a phrase, to do everything we can to try and have a child, to have a family, is very, very strong. It is very hard to give up the idea that doing the same thing again is not necessarily inviting the same negative outcome, especially if you are being offered new options, new treatment routes. I would imagine that if we had private cancer treatment clinics in the UK offering unproven experimental treatments, that they would be overrun. It may not be an exact parallel, but it feels quite close to me as a patient, as ultimately what add-ons offer to us is hope. While I was reading around a bit for this event, I came across Natalie Vermeulen's comment in a PET article that, quote, add-ons sit on the border between innovation and over-treatment. And my question, I suppose, to everyone here today is, how are patients meant to navigate that when even the clinicians don't agree? The HFEA's revised traffic light system will be, I think, phenomenally useful here. I should perhaps preface this by saying that I'm a patient who is already well disposed towards this system, and that is an important factor in how I've received it, as Tracey's just been saying. Having said that, it draws a huge amount of information together, and it breaks it down clearly and accessibly. The fact that the judgments are more detailed and more nuanced is really helpful. Expanding the ratings from 3 to 5 categories clarifies for us why treatments have been classified the way they have in a very accessible way. And it's also very helpful to have multiple ratings for different patient groups and also different treatment outcomes where appropriate. It's also really useful to have the definitions of each rating repeated on each page. It's very easy to navigate. And it now gives more information about the studies underpinning the ratings, which was something that I, looking at the initial system, was wanting, which facilitates informed decision makings. Including the links to the studies for anyone who wants to look at them is extremely helpful and gives a kind of reading list, which would be very difficult for a layperson to assemble themselves. I know that because I tried. It's also very useful to have a link to the SCAC minutes, the AAC minutes, where you can actually see more detail on the decisions made for each treatment. I particularly liked the questions to ask your clinic section, which is really useful. I really wish I'd had that when we were going into this. And I can really see how it will help patients to have the conversations they need to have and the confidence to ask things they need to know. Do have some reservations. The grey, and as people have already discussed, the grey and possibly also the amber ratings are quite open. I mean, I know that reflects reality. It reflects the state of scientific knowledge. That's understandable. But it is tricky to know what to do if you're thinking about having a treatment that has an ambiguous seeming rating. The HFEA recommendations do have more detail, which I think might be helpful to add here in a patient-facing resource. There do have to be also questions, I think, for anxious people like me about the actual feasibility of things like RCTs or big cohort studies on rarer issues. What if the treatment isn't there? What if the facility to do the research, the research isn't there? What if there is no funding for a large cohort scheme study? What do we do? Does it mean that you shouldn't try that treatment? I suppose my main question, and I'm sort of reacting slightly again to what Tracey is saying, is how do you get this to patients, especially the ones who are getting different advice from their clinics? As I say, I'm well disposed towards this system. I was pleased to see it. I will be recommending it to lots of people. I had an interesting conversation with somebody on a WhatsApp group I'm in when they were talking about the ERA test, where I said, oh, by the way, the jury's still out on that one, maybe check out the HFEA ratings. And they didn't really want to hear it. And I understand that. I really understand that, because what they're hoping they'll get from the ERA test is something that will make next time different. And no one really wants to hear that maybe it won't. Maybe that expensive thing you're spending your inheritance on or whatever isn't necessarily going to work. So I think there's always going to be an issue here that, how does the HFEA avoid preaching to the choir, the people who are already convinced? I think, having said all that, I think this traffic light, the revised traffic light system is fantastic. I think it gives patients who want to engage with it a really useful tool to make genuinely better informed decisions for all, the issues with it we've heard about this evening. I do think the overwhelming problem is always going to be how to connect with people who do not want to hear that perhaps these treatments might not offer the hope that we also desperately want when our treatment fails.
Now, before I go to the questions, is there anything, I was thinking particularly of Tim here, that he wants to come back on as he spoke first, which now seems quite a long time ago. So if there's anything that came up in any of the others' presentations, not from the questions, but from their presentations, I'll let you have a go and then I'll go to questions.
No, I thought it was very interesting seeing the different takes on things from the subsequent speakers to myself. Again, just to reiterate, the whole aim of the HFEA guidance is to try and give an unbiased view of the evidence for patients. That is what it is aimed at. It's not aimed at the sector. It is aimed at patients, at giving them unbiased guidance to dig deeper. But I'm obviously happy to discuss further as the questions come through.
Okay, so quite a few questions. So I'm going to, there are a few about PGTA. What a surprise, the chair says, as someone who's, I think we actually did an event once when it was called PGS, to try and get to the bottom of this. Anyway, so James Cafton asks, Tim, can you please explain how the HFEA considers it appropriate to rate PGTA read in the summary page indicating generally that there are potential safety concerns and that the treatment may reduce effectiveness, when the detail for PGTA shows a red rating only for increasing chances of having a baby for most fertility patients, for which it should not be used in any event. 1 green rating and 2 grey ratings. Do you accept that this is misleading to consumers who only view the summary? And I suppose I had an additional question in that, because you had a screenshot of that page on your slide, because it said, in older women, and I think there is a question about that. What is older women in this context? It may be not what we think it is. So if I'll let you start on that one.
A very good question. I mean, in the end, on the website, on the page it's being spoken about, it is very, very clearly written that this refers to the use of that add-on for most patients, and does it increase the live birth rate, i.e. what the original add-on system used. And it also states that for more information, patients can click through to then find out more. It's difficult because the alternative approach would be just to put all of the information on the home page, but then that also we've sort of heard that perhaps there's a lot of information there, and that might potentially be a bit confusing if the first thing you see is just lots of lists of things, because some of the add-ons actually have quite a few, much more than 4 outcomes that are there. So, listen, I think, as I said, all feedback is taken, and if we can, go back and look at it and try and improve it further. But I would say it does actually state that, we have to. This is aimed at giving patients information. We have to hope that patients are actually going to read what's written on the page there, and then make decisions from there. Now, in terms of the age side of things, you can't really say we said that more than older patients is more than the age of 38, and then the only study looked at patients over the age of 40. Well, that means that study couldn't be used. So we had to be pragmatic about it. And when studies are done within assisted conception and maybe focus on older patients in the title, they'll all have different types of age ranges. So what we were looking for was, were there any randomized or even other good studies that were focused on older patient groups? And if one was age 38 and above, one was 42 and above, we would have looked at that, but really they didn't exist.
Okay, does anyone else want to come in on this? I'm not seeing anyone saying yes, but there's, I think, another point of the HFEA in listening mode is someone's an anonymous attendee has said, why does fertility clinic search and choose a fertility clinic service on the HFEA website still, after all these years, have PGS as a fine tune for your search when searching for a clinic? This is an endorsement for PGTA, which is an add-on, and there isn't any signposting to information about add-ons in this accompanying search option. Talk about mixed messages to patients. I think that's quite an important thing that perhaps needs to be tidied up there on the HFEA's website.
I would agree with you, and I guess PGS, people still do talk about PGS, and whilst people perhaps in the PET forum here are using PGTA, there's a lot of people out there who still call it PGS. So you can't sort of just dismiss a term because we don't use it ourselves now. But I agree, it should be really clear that the preferred term now is PGTA, and I'd also agree that the system can be improved further to help signpost towards the add-ons, which again is the aim, to get this as widely read as possible by patients.
Yes, because I think it is quite misleading if you can filter, and one of the filters, because there aren't many filters in the HFEA's choose a clinic thing the last time I looked, and so I think it is quite misleading. So I'll move on to the next question, which is for Joyce, and it's from Manuela Parota. Joyce, thank you for your insightful presentation. Given the significant evidence gaps, what are your thoughts on improving evidence production in this field?
We've been trying to encourage clinics to do evidence-based research for a long, long time, since the 2011 paper. That's what we called for, and we're still saying it. And with PGTA as an example, I mean, there have been a number of RCTs, I must admit, but I think PGTA is done in at least, I'd say, 100,000 patients per year. If we look at the USA, last time we looked at the USA, I think it was something like 58,000 cases in the year, just the USA. So one of the troubles with the low quality of the RCTs that we're seeing is that they're low numbers, not all the problem, but one of the problems. And if you're looking at these scales of these so many patients going through a procedure, and things like time lapse, the list goes on, all of the add-ons really, especially on the HFEA list, they're used so much. So we've been trying to encourage them, but we've got ourselves in a real mess at the moment. What patient is going to want to embark on an RCT where they might be in the control group, when if you look online, the information is saying that these procedures have been done for, PGTA-As like over 20 years. So I think almost we've got to draw a line with what we've done, and I think it's a mess. But any new technology, as I said in the conclusion, any new technology that comes out, we need to please do this properly, and we need to do the studies before it gets embedded in treatment. So we've got to go. I know that they're expensive to do, but we've got to try and encourage clinics to do them.
Manippo, do you want to come in on that one about how do we improve evidence in this area?
Yeah, I mean, obviously I've been looking through all the questions as well, and the problem, and I will answer actually 3 of the questions as well, one from Minion, from Anonymous, and from whatever, is actually the investigations part. So actually some of the questions is, will clinics have a disincentive to investigate unexplained infertility or find causes of failed infertility so they can do add-ons? The problem is that the investigations themselves are add-ons, because we don't actually have good triage of understand why things don't happen. So microbiome testing and endometritis testing, hysteroscopy testing, DNA sperm fragmentation testing, immune testing, they're all tests. They're not treatments. They're tested and find a treatment, but the tests themselves are not validated. They're not well understood. We don't understand the biology. So, the question that we need to work up people more, and then we don't need add-ons, actually is a contradicting one, because the tests are add-ons themselves. So that's sort of the basis. The second thing, we don't understand the basic biology. So I think that is sort of the issue. But when it comes down to why we don't have the evidence, I think things are being rushed too quickly into being commercialized. I spend the majority of my time with add-ons telling people why they shouldn't have add-ons, rather than actually selling or giving or advising for anyone to have any add-ons. The problem is now it's an international world, so people read stuff from outside of the UK. And again, answering another question, the issues from around the world, most of the patients, most of the wild west of use of add-ons comes from outside the UK. The UK actually, despite all the issues, is only a very small issue problem. If you look at that slide that I showed about the percentage of people that use add-ons, it said in private sector, most was 70 to 80%, but even in the public sector was 50%. That was not UK clinicians necessarily. So you have this international sort of information, PRP, very rejuvenation and everything. Patients don't want to be part of the studies. Studies take decades to do. And the problem is also in the UK, they're very difficult to do. I mean, I've been trying to do a number of studies. We get bogged down constantly with ethics and groups and consents and regulatory stuff. And they're just difficult, not just costly. So I think it's a host of things out there. I don't know if I answered the question. I think I've answered other questions, but I think I've got it together.
Joyce, did you want to come back on any of those things? Because Ippokratis has wandered into other questions before I've asked them. So, but I think there's probably some comments that you'd like to make there.
No, just that I do think it's a mess. In the UK, the Competitions Marketing Authority, because of the limitations of the guidance of what the HFEA can actually do, they came in a few years ago and looked at what information we were putting out on websites from clinics that in the UK. And the information, we've published a few papers on that. The information is really, really misleading. So I appreciate that the clinicians will say that, they're trying, and I know that they are, some are trying to undo what the patients are coming into the clinic and demanding. And one of the clinicians said, it's like they come in with a shopping list and they're demanding these things, and we have to try and tell them that it doesn't work. So it's a rod for their own back too. But some of the clinic websites are really, really misleading. And unfortunately, the Competitions Marketing Authority has checked after their guidance came out that the right information is on UK websites, and it's not. There's still misleading information. So we in 2024, we shouldn't be having this conversation. We started these conversations before 2010, and I think we're in such a mess, and it's really unfortunate. I've been an IVF patient, as I said. You are a really vulnerable person. You will do anything that you think might improve your chances of getting pregnant. So if someone says you stand on your head every day and drink a glass of milk, you will try. I tried loads of things. So I think it's a travesty that we are misleading patients with really propaganda about different treatments. And I'm sure the clinics really want to support their patients and help them. But then I don't understand why these things are offered again and again and again, and we're misleading our patients. And it makes me very, very angry that we've wasted all these years. And I don't think Tim said there were documentaries out saying things about the natural killer cell tests, etc., etc. And I heard that after that documentary, the number of people requesting the treatment that they said really didn't make any sense and didn't work, the number of people that went into clinics the next day asking for that treatment went up. I mean, we're really dealing with vulnerable people. You give them a little bit of misinformation and they will run with it. So, it's really sad.
Yes, it is always a concern for PET as well when we discuss these things, that actually just by talking about them even in a negative way, we're actually advertising them. Tracey.
Just to almost be the defender of the patients, vulnerable but often mentally well and often able to read the HFEA website, and I've read so many different websites, they're aware that there's no evidence. So although there can be a desire to want to request a treatment that they're paying for, that they want to give it a go, or a test that they want to give it a go, it's not because they're not reading the information or they're ignoring it, but there often is, I need to do one more thing. And I don't think that puts them into the vulnerable, mentally incapable of making an informed decision, because I don't think anyone's doing anything wrong or exploiting patients. When you look at the clinic websites and the patients that I speak to, 99.9% of the patients, the doctors isn't supportive, and they've said there is no evidence about that. It's clearly documented that there is no evidence to support that, but we can provide the treatment if you want to. There's not enough evidence for us to make it routine. So again, it feels the CMA coming in has made it more of a supportive environment for patients to be able to make that decision with all the facts.
Does that circle back really to the provocative question that Ippokratis was making earlier, really, that actually by offering patients in that sort of situation that you've described, Tracey, is in fact helping them to stay on the treatment journey, so to speak.
Absolutely.
And therefore, just by keeping them on the journey, they're more likely to have a child than if they don't have any treatment, if that makes sense.
But also more likely to have treatment in the UK in a regulated system that's safer, and not go overseas and come back with a multiple pregnancy if they would have got pregnant anyway.
Ippokratis.
Just because you mentioned to add on that, my disclaimer is I would rather use 0 add-ons and have 0 add-ons with don't have evidence. That is my preference. And the question was not that as clinicians we should be offering to patients the add-ons to keep them in, is should we be didactic and say an absolute never, or should we have an approach to say, well, I don't agree with it, but I will allow it if you're going to keep you in the program. I don't think as clinicians we should be advocating add-ons. Or maybe just to clarify, I want it to be a little bit controversial to the conversation, but I don't think as a clinician we should be advocating add-ons that we know don't work just to keep patients in the treatment program. But if the patients themselves want them to remain in the treatment program, that's a slightly different question. And I do need to answer a question specifically just for me, and it was a bit provocative, and I'm sorry again that I'm doing this, but should people be charging for add-ons in the clinics in that sort of context? And the question was to me, which is why I as personally have to answer to it. Actually, in my clinic, we don't charge for any add-ons. the embryo biopsy is the only one we charge for PGTA, but that does not mean that I can speak on behalf of everyone what they should do, and everybody, the CMA also has an opinion about it and the rest. But that's a different sort of discussion altogether. But I had to come back and answer that particularly because it was specifically answered to me, and I wanted to make a point of what my question was about and what I stand for, rather than it's not about telling people to have add-ons. But I don't think at the same time, if you have a thorough, proper discussion, somebody can understand what you're talking about. I think there's a little bit of leeway rather than just be completely black and white about it. Hence why we have 5 colors in the new traffic light system.
Okay. I'm going to go to the next question. I'm going to go for the one from James Lawford Davies, who says many, if not most, of the rated add-ons are also approved by the HFEA as authorised processes for use in the lab. And he helpfully puts the link in. I haven't had a chance to follow it. Irrespective of whether the rating is red, black, grey or amber, isn't it inherently confusing that the HFEA authorise these processes for use while also saying that they are somewhere between dangerous and dubious? I think we'll go to Tim for that one as you're on the HFEA.
Yeah, I mean, I sort of disagree really with James. If you click on the link there and if you look at the list of the authorised processes, essentially it's authorised laboratory procedures. So ICSI is an authorised process, IVF, fertilisation, embryo culture, etc. And there are 3 on there: PGTA, assisted hatching, and intrauterine culture are 3 authorised processes, which are also on the add-ons list. There's embryo culture, which would be a 4th one, which I guess you could cross over into time lapse, but it doesn't actually say time lapse as an authorised process. So I think he's wrong to say the most or majority, whatever the words were. And the authorised processes are things that, if the HFEA to say something can't be done, again, we're talking legally here, because this all goes back to the 1990 Act, the HFEA to say something can't be done essentially has to be unsafe. And so, PGTA, when that was first went onto the list, whenever that was, it wasn't shown to be an unsafe procedure to do. Obviously, essentially, it's the biopsy would have come from the initial testing was the PGT. Joyce will know more about this than I do. It's her area, but obviously that was done initially, looking for. It was embryo biopsy was the main issue. So I would disagree with James there. I don't think it is confusing because the authorised processes are authorised laboratory procedures which are allowed by law. I can see Joyce raising her hand.
It's Joyce.
Yeah. Thanks. So when PGTA came out, I was at every meeting of the HFEA saying we've got to do something. And unfortunately nothing happened. But I know they have limited powers. But I absolutely take James's point, and it's what I was saying in my conclusion. I think that Act needs to be changed, and it needs to be changed now, because the HFEA really want to do something about this.
You can't just change it now. It's not how it works, Joyce, as you know.
Yeah, but we've been talking about this since. I mean, I was on SCAC 10 years ago when we started talking about this, and so if a new procedure comes forward. I can't think of anything wacky enough, but say if a new procedure came forward, the HFEA are only allowed to approve it on, as you said, on safety grounds, and that just doesn't work with what they're doing with their other hand, with the add-ons. And I think we need to have, as I said, a research license where a particular institute or lab or clinic or whatever is allowed to test a procedure under very vigorous clinical conditions to say, is this going to be of any benefit to the patient? Because that's what the add-ons the HFEA has produced. It's talking about, it doesn't talk about safety. It talks about, is it going to help you have a baby? So we shouldn't be licensing new procedures that there's no evidence for that and making the whole thing more complicated. We need to start moving forward and being proactive rather than just waiting till we've got a massive problem for 20 years and then saying, oh dear, and then getting really confused.
And I would agree with you. I mean, it's essentially, as has been mentioned many, many times this evening, the HFEA essentially is ensuring that the Act is followed. So this is down to an Act of Parliament. And it is so the HFEA were asked by the government as part of the women's health strategy, to look at what new powers we would like, we need to be able to tackle add-ons, because at the moment we don't have them. So, I completely agree with you. It'd be great if we could do this, and this, but we legally can't, in which case you can't do it. So there has to be a change in the Act of Parliament, which there are plans for that, but when that's going to happen, I don't know, particularly with what's happening this year. I agree with you, Joyce. I agree with you.
I'm going to move on now with a question from Katie Howe. Are clinics obliged to reference HFEA or HFEA ratings on their patient information leaflets about add-ons? I think we should also include websites there. I'm not sure that the age of the leaflet is dead, if not dying. And if not, why not? And then I'd like to then go to Tasha on that one to say, if that information were there, what does she think its impact may be? Okay, so who wants to go on that one first? Is there an obligation to do that? We'll go with you on to answer that one, Tim, in your HFEA capacity.
Yes, so clinics are required to give information on add-ons, and that comes from the HFEA site. So yes, they are required to reference the HFEA for that. There wouldn't be a requirement to reference the excellent ESHRA guideline. That can't be, again, it can't be something, it's not within the remit of the HFEA to do that, which I guess is a shame. But hopefully the ESHRA guidelines are mentioned within the HFEA add-ons section, so perhaps people will also sidestep towards that.
And is there, sorry, this is my ignorance, is there any sort of way that that clinics are expected to do that, because we all, can be in the small print, it can be there, but not a link on a website to make it a bit more difficult to follow. Is there sort of best practice for that?
As far as I'm aware, there's not a certain level of font size or what have you that's again, it's written in the code of practice, but during the inspection, as you'll be aware, the regular inspections of licensed centres, it is expected that the inspector will be able to see that clinics are suggesting patients look at, are given this information.
Can I just add? Sorry,
yes.
Can I just quickly add that the ESHRA group have been working on a patient brochure that will be a patient-focused summary of the ESHRA recommendations, and we mustn't forget the ESHRA obviously is much, it's supposed to be EU, but it's much more global than that. So it takes those recommendations.
Good. And Tasha, what do you think? Would it make a difference? And how much of a difference do you think it may make? Sorry, and it's a very speculative question.
I think it would depend a heck of a lot on how it was framed. Really, and I can't, maybe I'm being cynical, but I can't imagine a clinic that was willing to put. My experience of add-ons was that the clinic was very pro. That particular clinic was very pro, and I have had conversations with clinicians in clinics where they offer add-ons, where they have said, I spent most of my time, like Ibo said, trying to tell people not to do this and telling them why they shouldn't do this. I think it's extreme. I mean, going back to what I was saying earlier, it's extremely difficult to offer somebody hope on the one hand and then take it away with the other. And I think a lot of patients do not want to hear it. I don't think I would have done if you'd told me when we were in the middle of it, this is a waste of money, it's not going to help you. I think that the fear, I mean, Tracey talked about this a bit, but the fear that you have as a patient that you are not doing, you're not taking that step that might be the one thing that pushed your chances into actually working, are incredibly hard to resist. And I certainly had experiences in clinics where implicitly the message was very much, we in the private sector, we are able to innovate in a way that the other sectors aren't, because they're limited and they're held back by government government rules on what they can and can't do. I think it would be very easy to frame giving somebody a leaflet with the guide to the traffic light system on it in very small print at the bottom as precisely that. I think as long as these things are available, this is going to be a completely self-perpetuating problem, unfortunately. And without wishing, obviously, to stifle innovation, luckily I'm an English lecturer, I don't have to solve this problem, but it's very hard to see how you can square that circle. I think I'm not. In all honesty, I suspect giving people a leaflet in the clinic won't probably do very much.
Yeah, I'd be really interested to hear if anyone's aware of a clinic website which says, actually explicitly states, we don't do add-ons, or we don't offer this because it doesn't work. Don't, if you want this, don't come here. I don't look on clinic websites as often as I should for nosy purposes, but I would love to hear if anyone knows of a site like that. So do let us know at PET. I'm sure you can't see Joyce is laughing. I'm sure she would love to see it as well. Okay, I'm going to move on to some other questions now. So I think one very simple one, and I know it's something that we talked about quite a lot on the HFEA working group on add-ons, was should ICSI be recommended over IVF? And it's something that that is potentially green in some situations, or whatever colour we're using and system we're using, but not in others. Joyce, do you want to go first on that one?
Yeah, I think let's talk about ICSI being green. So ICSI is used for two things. It's used for male factor infertility and non-male factor infertility. And if ICSI is used for male factor infertility, it is not an add-on. There is no choice. It would be crazy if the man had poor sperm parameters to not use ICSI. So that is absolutely not an add-on. And just as in my view, using freeze all if the woman's hyperstimulating, that's an essential treatment. So that is not, those aren't add-ons. But using ICSI when there's no male factor, with the view that you think it's more successful than IVF, there are very robust studies that have been done, and it's not recommended. It does not show a higher live birth rate, and I think that's very, very clear. So yeah, I know that on the HFEA website at one point, my students have to do an essay every year, and they have to write about add-ons. Surprise, surprise. And a couple of them last year said that ICSI was had a green traffic light, and I went crazy at them and complained and said, "What are you talking about? ICSI's not green. ICSI for male factor." And I was like, "That's not green." And then it was on the HFEA website that ICSI for male factor infertility was a green add-on. And I don't know if it's still there, Tim, but
so it's not.
I sent a lot of.
Yeah, it was on the old one, which I hate to point out was during your time, not mine. But so it's.
I couldn't believe it was there. We never approved that.
No, well, okay, SCAC approved it before, but it's certainly it's not on it. It's not on it now. Pixie which is obviously an add-on, because it's an add-on to ICSI, as I mentioned in my talk. But I would completely agree with you. There's no benefit in ICSI for all patients.
Anybody else want to come on ICSI? A sort of another sort of technical question, really. Marcin Smetana, a question to Tim and Joyce. What do you think about the different assessment of embryo glue between the HFEA and HFEA on their advice on add-ons? Who wants to have the first bite at that? Well, perhaps let Joyce go first, and then Tim, because the HFEA published before HFEA, so we'll go in that order.
I don't know how much I'm allowed to say about the HFEA discussions around that, but there must be minutes somewhere that minute this. But it was discussed at length, and it caused a lot of controversy. And in my personal view, it was almost green at one point from the HFEA, but then it didn't. So obviously we knew that the ESHRA group knew that this did not agree, and in my view, it's the most startling of why it doesn't agree. I'm going to be controversial now. I personally think one of the problems with it is that it's, as far as I'm aware, is it only made by one company? I'm not sure. I've never bought it, so I don't know. If it, and I think it does cause controversy around that. So yeah, what the ESHRE group looked at it, and we just did not feel that the evidence said that it didn't work. The evidence said that it did work. But Tim, tell us about your recent discussions around this. It's a tricky one. It's a really tricky one.
Yeah, it's a tricky one, and you know, it's one of these things where you as people, if you're doing a meta-analysis, you're putting a number of studies together. It depends on which studies are included, which ones reach the threshold for that. So that's why you get different meta-analyses results. So essentially, partly it can be that. Although from our point of view, we'd set down the guidelines that for something to be green, there had to be a certain number of good quality studies, and it didn't meet the threshold for that. So it was close to green, but not green in the thresholds that we had set beforehand. Having said that, in my team in Oxford, we did a study of 900, a randomized control trial, 900 patients, not yet published, but it presented at ASRM last year, showing no difference with embryo glue or not. So I'm pretty sure that once that is added in, it's going to pull it back from green. So you can see it's equipoise, I would say.
Far as we're going to get with that, I think. So a question from an anonymous attendee is safety not the most important issue here, and patient safety? And I think that also ties into a question that was in the chat, which I'm not sure whether ESHRE or the HFEA considered, and that is about any impact on the child that is born if the treatment is successful, and is that factored in this, which does also really tie very importantly into that question about safety being the most important issue. Tim, do you want to go on that? How much weight did HFEA put on that? Was that the most significant thing?
Yeah, I mean, obviously, safety can mean a number of different things. So safety can be an add-on reducing the success rate. Safety can be causing harm, because harm is a reduced success rate. Harm is also someone getting OHSS, or a complication of having intravenous immunoglobulins. So there's no threshold for what is safe and unsafe, and obviously there are risks of having IVF. OHSS is unsafe, and that goes along with IVF. So it's where do you set the threshold? We had a lot of discussions around, I remember IVIG, also risks of OHSS, etc. So that it did factor then. I would completely agree that safety is paramount, but it's not a black or white thing. That is why I think having, from a SCAC point of view, having 14 people all working within the sector, in the widest sense of that, because obviously there's patient representatives as well, patient support representatives, you can get a view drawing that on what is felt to be safe or unsafe, but it'd be difficult to put on paper exactly what meets the criteria for unsafe.
Anybody else want to come in on that? I can just see Joyce nodding. Okay, we've only got 5 minutes, so there's a couple of comments in relation to the question I put out there about clinics not offering add-ons. And so Ava Gonikowska, apologies if I've mispronounced your name, says Bridge Clinic London doesn't offer any add-ons and informs patients about that. And Alison Motluck has said, didn't the erstwhile BPAS Fertility clinic say they offered no add-ons, and that BPAS clinic is now Bridge Clinic London. So that sort of ties that up. There's a question that for Tasha, which is, do you think doctors should offer add-ons and charge for them just because a patient wants them? And when Tasha's had a bite at that, I'm going to go to Tracey for her views on that.
That's a horrible question. I don't know.
Well, do you want me to go to Tracey while you're having a think?
I mean,
you can do that.
I think I'm all right. Essentially, I think that part of me thinks the answer to that is no, they shouldn't be on offer. You shouldn't be able to access a medical treatment that exists just because it exists and you can pay for it, regardless of harm. I think that I can see the counter argument to that. I think this partly comes out of my being aware that for most people, for me certainly, their first experience, probably their only experience of private healthcare will be through IVF. if IVF was funded properly in this country and there was proper access to it, then presumably there would be greater regulation of, you know, clinics that would be then working through NHS funding, and you would have the same kind of approach, a much more uniform approach in clinics. I can see that there are problems with that. I also feel quite strongly that while I completely agree with Tracey that I'm slightly cautious about sort of labelling people in my position, you know, particularly as vulnerable. I think we are vulnerable. We are also capable of making properly informed decisions, but the stakes are so high. And when you're sort of looking at whether you're going to have a family or not, and you are in a position where, as I was talking about my own experience, where you're basically making clinical decisions you're not equipped to make, then I think you are vulnerable there too. I would prefer it, I think, maybe if there was, you know, I think, blame my parents for this. I was brought up in a very pro-NHS, anti-private medicine family. I feel quite strongly that actually, you know, the access to healthcare shouldn't have nothing to do with your ability to pay for it. Which is, I think, a separate issue. I think the genie's out of the bottle with this one. I can't quite imagine it being put back, but I think I would have preferred it had it not been let out in the first place, perhaps.
Yep, I think that's Tracey, is there anything that you want to add?
Just absolutely. If treatment was funded fairly and followed the NICE guidelines as the NICE guidelines were written, I think there'd be far fewer problems, because patients would have an appropriate approved HFEA seal of approval, 3 cycles where appropriate, and wouldn't be looking for all the add-ons, because hopefully they'd have had success in a fairer system.
Yes, and I think that we certainly I've heard from colleagues in other countries where they have a better state funded system that actually the appetite for add-ons isn't there in the same way that we see here.
Yeah.